And just a huge welcome and thank you for all of you who have been part of this process to pull together this first regional session, as well as all of you coming in to get some good information today. We're really looking forward to start this conversation and engage with all of you on this effort. If we could go to the next slide. Thought we'd start off just telling you a little bit about who we are. So as I mentioned, my name's Sadhana Devaraja. I'm Managing Director here at HealthBegins. We're a national mission-driven consulting and training firm. We focus on social and structural drivers of health equity. And we will be, and for this project, we've been working with Aurrera Health Group, which is another great firm working specifically on Medicaid, Medicare, and behavioral health policy and financing. And we are able to do this with the generous support of the California Healthcare Foundation, if you go to the next slide. And so we're really grateful for their support in pulling this together. And finally, we would be remiss on the next slide if we don't acknowledge our implementation partners who have been helpful in pulling together this content, responding to content, and will be on the line today to help answer questions as well. This is certainly a team effort. And so I really encourage everyone on our project team to jump in with answers because not any one of us, I think, is an expert in all things that'll come up today. I also want to extend that invitation to our plan partners at Partnership Health Plan of California, at Health Plan of San Joaquin, and HealthNet as well. So as we go through the content today, we'll really be pulling from all of the experts around the room here to get to our objectives. And so our objectives for this session are that everyone here will be able to find relevant information and resources to understand CalAIM requirements. I'm sure if any of you have been kind of navigating this terrain, there's just a lot to know, and we're not intending to cover all of this in one session or even two sessions, but part of the work that we'll be doing is wayfinding, so directing you to where that information can be found. We're hoping that folks will be able to define community supports of interest to the managed care plans that are in your counties, that are in your service areas, that you'll be able to describe the key domains that CBOs can use to assess your own readiness to contract with managed care providers and provide those community supports, and then set everyone up to complete a CBO Readiness Assessment to be able to stay involved in this partnership development work. So we've created a CBO Readiness Assessment and are hoping that folks, as a result of the session, will have enough information to be able to take that assessment and see where your community-based organization lands. So to get us started, maybe we could do some introductions in the chat. And folks can just chat in with your name, your organization, and let us know if it's not clear from your organization name, which county you're providing services to or working with. And so thanks, Alex, for the hello, and just see if folks can jump in here. Hi, Indy from Mom's Meals. Thank you. All right. I see folks jumping in there. And if you're on the project team, please let folks know that you're part of this project team. If you're part of one of the plans that's working on this effort, please, let folks know that you're part of the plans that are working on this effort. I see folks jumping in there. So this is our first step, is introductions. And then we will also be going through this agenda over the course of the next couple hours with a break in between there as needed. We'll be going through information and resources as our first stop. We will be talking about that CBO Readiness Assessment and some of the domains and then go do a deeper dive on some of the key domains to assess readiness. And we'll close out with next steps as the end. There will be this resources and appendix section that we're not reviewing in detail today, but when we send out a PDF of the slides, you'll be able to see the resources and appendix on your own. All right, good morning, happy Monday. So these are some assumptions that we have about today's audience based on what we've the research we've done and also what we've been told. So the assumption about today's audience is that you all represent California-based CBOs and that you provide services in Sonoma, Shasta, San Joaquin, and or Stanislaus counties. We know some of you span multiple counties. Some of your CBOs may be in one county in particular, or you might be county representatives in one of those counties. So we had a number of folks from those counties asked to be included, and because of the role that you've been serving in some of the existing pilots, it made sense to include county representatives from those counties. We're assuming that folks here are interested in partnering and building relationships with your managed care plan through CalAIM. And we also assume that this cohort that's here today, we've got 25 participants here today right now, but that cohort may grow or shrink as participants review the material from today. So we know that some organizations have invited multiple team members. You may decide that, that needs to be whittled down based on the content that you're receiving today. And others may think of colleagues at similar organizations to include in the cohort. And we just want to say that, that's still welcome, especially if you have colleagues at similar organizations where you think that as we go through the community supports that they might have services to provide related to that. They might be BIPOC led. If so, we would still encourage you to let us know about similar organizations and we can include them in here. The only other thing I wanted to say about that is that we're recording today's session specifically with that in mind, that, the cohort may grow a little bit and we want to be able to provide this backgrounding for folks that had to miss today's session. And also that slide deck that I mentioned before, we'll PDF and send that out. I'm wondering if we could do a quick just poll by chat right now and figure out one kind of last assumption about the audience so that we don't have to assume it, which is, how from a scale of 1 to 5, 1 being low, 5 being the highest, how would you report your knowledge about CalAIM community supports and kind of what the requirements are within it? So if you could just type 1, 2, 3, 4, 5 in the chat in terms of, how much do you think you know about what's needed to contract or what kind of the terms are. And the scale is 1 is the lowest and 5 is the highest amount of knowledge. So I saw a couple 4s, a bunch of 2s. I see a 3 with a question mark. I think that's what it's averaging out to, Don. So that sounds pretty good. All right, so from people responding, it sounds like kind of at a medium, like a 3 here. That's great. Feel free to keep inputting what you think your confidence is. And it's helpful for us because then we can kind of right size the content for what you may think your level of readiness is. And then, so to this last point about how the cohort may grow or shrink, if you go to the next slide, these were the CBOs that have been invited from each of these counties, and we included, some of the county partners as well on these lists. And we do have especially space open in Shasta and Stanislaus as folks think about your colleagues and your peers in this space throughout today. Feel free to reach out to us with additional names of organizations for any of these areas. Can we go to the next slide? So I'm going to do a quick little startup on information and resources related to CalAIM. So we weren't planning to make this like quite a one-on-one, but 101, but we did want to be able to share some key terms and make sure we're all using the same acronyms in terms of acronym salads. So throughout the slides, you may see some of these abbreviations taking place and through the language that we're supporting. So when we talk about DHCS, that's our Department of Healthcare Services in California. When we're talking about MCPs, talking about managed care plans, so these are the health insurance plans, the plans that are providing healthcare services for members. CalAIM is the California Advancing and Innovating Medi-Cal initiative, and it will be launching in January 1st, which is what we're here to talk about. Something that we're not focusing on through this cohort is one prong of CalAIM, which is enhanced care management, so ECM. So that's the managed care benefit that's addressing clinical and non-clinical needs through coordinated services. What we will be focusing on are community supports. And just to be clear on the language around that, it was previously called ILOS, or in lieu of services. Now the language is community supports. And that's important, just as we're all engaging today. And also as you engage with materials in the resources that we'll be, sharing and directing you to. Some of the language still says ILOS, and we're talking about the same thing when we talk about community supports. And so just a real quick CalAIM 101 over the next couple of slides. Managed care plans cover 83% of Medi-Cal beneficiaries in California. All counties have managed care plans, but the models are different for each county. And so you see this map that kind of showcases the different models of plans per county. And so the state contracts with managed care plans to deliver services under Medi-Cal. And so each of the managed care plans receive a monthly payment to cover the services in their contract. And so where CalAIM comes in is that it's a multi-year initiative that DHCS is starting up in January 1st, 2022 to improve with the aim of improving quality of life and health outcomes for those Medi-Cal beneficiaries. At the same time, the Health Home Program and whole person care pilots will be phasing out. They'll be replaced. And so if the CBOs on this call are familiar with those pilots, those will be phased out, and CalAIM, ECM, and community supports will be coming in their place. And so what are community supports? These are services that managed care plans are strongly encouraged to provide. They are not required to provide. And it's meant to be kind of a substitute for using other services or settings, such as hospital or skilled nursing facility admissions, emergency department use, things like that. So the in lieu of service language from before is because it's supposed to be this like substitution that takes place through community supports. So here we see county participation in enhanced care management and community support. So while managed care plans are going to be responsible for administering these programs, counties are going to be critical partners. And so, that's why, as I mentioned, we do have counties on the line. And just that I see your question about sending out this presentation. Yes, we will be able to send out this presentation after the meeting. We'll PDF it and have the links live to be able to send it out. And so here you see like some possible roles for the counties, and that January 1st date that I mentioned are really for counties that had those health home pilots and the whole person care pilots. And there's this expectation that, contracting with existing providers should be in place unless there's reasons for not contracting. And so counties who have been in those pilots know how to do this to some extent. And these are some of the possible roles for counties, especially in those whole person care and health homes pilots. As I mentioned on the next slide, you'll see some resources that folks can click through when we send out the deck. There's a lot of information on DHCS's websites and through policy decisions and guidance. Through the presentation today, at certain points, we might point out which ones would be helpful for what, because it can be overwhelming. But we did want to make sure that you knew that there are resources available, beyond this type of engagement, and we want to make sure that folks know how to get there. In addition, if you go to the next slide, there's these really great webinars that have taken place that do more of that 101 and 102 type of content on Medi-Cal managed care and CalAIM. So where I kind of ran through it right now, if you do want kind of a deeper dive and a deeper 101 on those terms and on, kind of how this all plays out over the next couple of months, then those webinars are a great place to start. We also included one that Partnership had sent us for Shasta and Sonoma. And I'm sure the other health plans may have additional webinars and TA efforts that they can share. And we'll just keep this running list of what's available in terms of webinars and resources for folks here. If we go to the next slide, the kind of last piece of the resources and webinars is just that CHCF is also backing this work. And so one such example is the Community Health Workers and Promotoras, the Future of Medi-Cal project. They have a resource center and resources to point to related to CHCF's work in this space. And so those are additional kind of non-DHCS, non-plan places that we can point you to in terms of better understanding the content related to CalAIM. Maybe before I go into the community supports of interest to local managed care plans, I'm wondering if I should just pause and see if folks have any questions and give a space for anyone else to speak up or add to even the resource list or, things that you found helpful. I'll just pause for a second and I'll see, especially if our plans have any additional resources or if CBOs have found anything on their own that they found especially helpful. Hi, Pamela, could you unmute and we can take your question here?
Yeah, thank you very much. Yeah, excuse me. Yeah, I've been following and tracking this process and just wanted to get some clarification on the reimbursement process for ILOS or community supports. It's a little bit vague in the draft contract language and wanted to know if you have any guidance on that. We currently have contracts for short-term respite care, both in Sonoma and Napa counties. In Sonoma County, it's currently through a grant contract reimbursement process through PHC. And then in Napa, interestingly, it is via per diem through the county of Napa. And I didn't know if there was any kind of new practice that was going to be occurring. Your thoughts on that? We're always concerned about getting too complex in the billing, which can be a challenge for us accounting wise.
Yeah, I understand. So it sounds like, you have different kind of billing statuses through different counties, and you're wondering if there's something kind of more standardized.
Yes, thank you.
No, that is really helpful. I know we're covering this a little bit. I wonder if I could ask, I think my colleagues at Aurrera were on, if I saw that. I don't know if Lucy or Jill are on. My understanding is that there's some good guidance, the non-binding ILOS pricing guidance that might be helpful, but I'm wondering if there's anything else.
Yeah, I didn't see that in the pricing guide.
Sorry, this is Lucy from Aurrera. Can you please repeat the question?
So Pam was describing kind of the different, she was wondering if there was like better information about the reimbursement process for providers for community supports, and that they're experiencing kind of different payment mechanisms per county, and wondering if there's any standardization that's, you know, expected down the line. And Pam, please correct me if I kind of characterized that wrong.
No, that was great. Thank you.
Yeah, so for the community supports, that will be up to discussions with your health plan. And the HCS really released the information they plan on releasing through the pricing guidance. So unfortunately, I can't provide you any more information at this time.
Thanks, Lucy. Yeah, so I think Pam, or Pamela, I'm sorry, that what you're saying has been right so far in terms of, I think you characterized it as being a little vague, and we'll have a link to that pricing guidance in this deck when we get to it in a little bit. And so maybe that'll give a little bit more clarity, but it sounds like it'll
Thank you.
Plan by plan. Thank you. Thanks for that question. Okay, so maybe with that, we can move to the community supports of interest. So these are the pre-approved, potentially medically appropriate and cost-effective community supports that DHCS has pre-approved. These are the ones that managed care plans can offer. Their managed care plans can also submit proposals for additional community supports, but DHCS will have to approve that. And so this is the list of the pre-approved community supports options. And I know that when I've spoken with some CBOs in the past, if you go to the next slide, the questions are, well, what do these terms mean? We may not be using those terms at our CBO, and some CBOs are more versant in this kind of nomenclature. And so one of the documents that we'll direct you to is the ILOS policy guide. And they have service term definitions in that policy guide so that you can kind of match up, you know, does my CBO offer these community supports, or does my CBO want to offer these community supports? And they give some detailed language there. We also have some slides in the appendix of this deck that we're not going to go over in detail to define these community supports, but we do recommend folks, especially if you're unfamiliar with the language of these services, to look and see if it matches what your CBOs provide. I will say that in inviting you to this session, folks did think on first pass that your CBO does provide relevant services, and particularly relevant services to what managed care plans in your service areas are interested in. So you should take a look at that policy guide. You should take a look at the slides in the appendix and kind of make that decision for yourself if you haven't already. We go to the next slide. So, you know, what we're embarking on here is the proposition that, you know, CBOs that are part of this call could become community supports providers delivering critical medical and social services, such as those listed here, and that these CBOs could contract with managed care plans as the primary responsible entity for delivering these alternatives, and that you could subcontract with other entities also as appropriate. And if you were to become a community support provider, you would have to meet certain contractual requirements, and that's, you know, kind of what we'll be reviewing today and through the course of this engagement. So things related to care models, billing, data sharing. If we go to the next slide, you'll see some of the community supports that have been planned for January 1st through the different counties and plans. And so there are some that are being planned for January 1st in Shasta and Sonoma and San Joaquin, and then kind of more to come in Stanislaus for July 1st, more than January 1st. Most of these you'll see are related to housing needs. Across the board, folks are also, plans are also interested in meals and medically tailored meals. And so that's where we've kind of focused the CBO cohort, is on housing and on these meal provision CBOs. If we go to the next slide, here is, I think, where I will turn it over to Rishi to be able to help get us through kind of the payment information and resulting slides.
Thanks, Adana. Hi, everybody. I'm Rishi Manchanda, CEO at HealthBegins, and want to express my gratitude to all of you, echoing Sadhana's sentiments at the top of the call, and to our partners, including those from the health plans who've joined us today, as well as the implementation team. Particular shout out and gratitude to our partners at Aurrera Health Group, who've shared a lot of wonderful content, including content we're sharing with you guys today. One thing I'll just encourage, just building on Sadhana's points at the top and some of the great dialogue we're seeing in the chat, is the purpose of this space today is not only for us to share slides, but for questions such as Pamela, your great question, to be asked, and those who have answers, especially those of you who indicated that you have more knowledge, perhaps compared to relatively speaking to others. If you have information that comes up in response to questions you're seeing in the chat or that gets voiced over, please feel free to share. And obviously that also goes for the plans. Pamela, your question, as Sadhana mentioned and Lucy mentioned, is plan specific. And so we encourage our plan partners who are on the call today to feel free to direct people to information or add email addresses where information can be, people can contact you, appropriate resources. So we're hoping that the chat at the very least serves as a function for information sharing in addition to the presentation we're giving today. In terms of, I think this is building on Pamela's question about reimbursements or payments, some baseline information for everybody, especially organizations that indicated that you're at a 2 or 3, in terms of knowledge at this point. We wanted to recap some important information. First, payments. We know that for enhanced care management or ECM payments, that managed care plans will be paid fixed PMPM or per member per month capitation payments for this benefit. Those rates were finalized in September. For community supports, or formerly called in lieu of services, DHCS has provided pricing guidance, and it sounds like some of you have already come across that pricing guidance, to plans to support discussions regarding those rates between plans and potential community support providers. That information is not publicly available. It's obviously very specific and has been shared with the plans. That guidance, the pricing guidance in general, has been based on a set of well-researched assumptions. I think Mercer, an actuarial firm, was involved along with the state to put that guidance together. But it's important to know that that guidance is not binding on managed care plans or community support providers. And really important point here is that the rate that's agreed to between a managed care plan and a community support provider, including some of you today who might choose to become a community support provider, it could fall outside the rate range presented in the pricing guidance. And that's this is an important point that DHCF itself has indicated. And as you know, given what community supports are in terms of being cost-effective alternatives or meant to be cost-effective alternatives, it's important to note that funding for community supports is already built into the capitation payments, the PMPM payments that plans will receive. What that means is that managed care plans are not receiving additional funds for community supports. And I think some of you, perhaps who have already been studying this closely, are aware of that. But that's an important bit of information we wanted to communicate to those who are less familiar with how the payments work. When it comes to the plans will pay contracted community support providers for services based on negotiated rates. Plans are encouraged to tie payments to outcomes. This is both for ECM as well as for community support payments. And lastly, the rates that plans offer providers, it's important to note, are not standardized. And we heard that in Lucy and Sadhana's response, Pamela, to your important question. We know that these rates will vary across plans, across counties, and that variance will be driven by factors like program structure, staffing ratios, size of the facilities, geography, payment models in particular. One thing that we'll highlight here, and this is one of those key resources that Sadhana mentioned that we'd be kind of focusing in on, we really encourage to start to get a better sense of what those factors look like and how to think about what it means for CBOs to understand the pricing and the rates that you need to seek to engage in this work. We encourage you to read guidance that came from DHCS about these variables and how that might impact pricing. There's an example that DHCS has provided in that guidance that I've highlighted here. For example, what happens if there's a variation by caseload, and what does that mean in terms of the rates that you need to be paid, or that the plan would negotiate to pay to you as a CBO. In other words, caseload variation, geography, staffing model in general, these are important factors that we know each of you as CBOs are going to be considering. And this guidance can be very helpful just to think through that. And again, for those who've already used this, this guidance, Pamela in particular, it sounds like you've come across this, please feel free to add in any information in the chat that you found to be helpful or questions that have been raised as you've read this, because that can be really helpful for CBOs that have not had as much experience in looking at this resource. When it comes to payments, another important feature is not just about the rates, of course, for community support providers, but also understanding the infrastructure payments that plans will have available. So DHCS is going to establish or has established plan incentives linked to delivery system reform through an investment in infrastructure for community supports as well as for enhanced care management. Those incentive payments are going to be based on quality and performance improvement measures. And the target of those payments is to drive change at the plan level as well as at the provider level. That goes for ECM again, as well as for community support providers. Those payments are going to be directed largely to plans, but DHCS is encouraging plans to partner and share those incentive dollars with providers to be able to achieve those defined targets of quality and performance. And so you might, if you haven't already, heard in your conversations with, again, specifically with plans about the use of incentive payments as well to invest in infrastructure. And again, invite our plan partners to kind of comment on that in a minute when we break for questions. One of the priorities, as I've indicated, for the incentive payments from DHCS is building infrastructure for community supports to build the capacity of providers. And so you can see here an example of some of the measure domains that DHCS is indicated initially in terms of how incentive payments can be used to support community support infrastructure building. I'll pause here and just break for questions, comments, especially any resources that might be helpful. And I'll look through here. Jenny, yeah, the recording of this meeting will be made available, and we'll take the slides, including the live links, as Sadhana mentioned, and put those into a PDF that you'll be able to access as well. But I'll pause here. Maybe I'll ask anybody from the plans, whether it's HealthNet, Health Plan of San Joaquin, and/or Partnership Health Plan who's on the line, to see if you had any kind of clarifying comments or suggestions based on at least the information about how plans themselves will pay community-based organizations who can become community support providers. Anybody in the plan side that wanted to at least offer comment to let us know, at the very least, if directionally this is right, or if there's any additional information or that you think would be helpful for CBOs to understand. I'm looking to see on the screen if we have anybody. We'll have it on the CBO side. Any questions, comments? Again, looking at the chat, or feel free to unmute yourself if you. So far helpful? All right, well, let's keep going. Let's move to the next page and to the next slide here. And as I do so, I think an important question for us is really how useful this information is. That question that Sadhana asked at the top in terms of 1 to 5 and your knowledge level. Hopefully, this is probably more meaningful for those who are just at the earlier stages, who indicated 2 or 3, perhaps compared to those of you who have a more developed knowledge base already about community support contracting opportunities. And so please let us know for those across that spectrum, if there's any particular questions that you want to make sure that we address. This is not just about us presenting again, it's really about engagement, tailoring to your needs. One thing in particular to kind of understand how to tailor to your needs and help you and other CBOs like you in these 4 counties in particular to get a quicker sense of whether there's a fit here, whether there's an opportunity to engage in direct contracting, or even to assess whether you'd like to engage in indirect contracting relationships, for example, becoming a subcontractor or working with a local intermediary. Our hope was that through readiness assessment, we'd be able to help CBOs, including many of you, understand and triage what domains of readiness are required by the plans and by DHCS, and then decide whether you want to pursue either direct or indirect contracting mechanisms more quickly. And so we're going to share the readiness assessment with all of you at the end of today, and you'll see that as part of a follow-up email shortly after today. But at a high level, this CBO Readiness Assessment is something that HealthBegins designed with input from our partners. This tool is designed, this readiness assessment is designed to help CBO leaders identify basic capabilities required to be a ECM or a community supports provider. It's been developed with great input from our plan partners, implementation partners, and other subject matter experts. We're hoping that CBO leaders can use this assessment, this readiness assessment, to inform decisions, as I mentioned, to pursue direct or indirect contracting relationships, as well as to identify the specific technical assistance needs that your own CBO might have and opportunities to build provider capacity. It can be a helpful starting place, but it's not meant to be a replacement for any plan-specific provider assessments that, in some cases, some plans have already developed and are requiring for those that they want to work with. And so CBOs that decide to pursue direct contracts with plans are really encouraged to complete, of course, any plan required assessments. And then some of you will see, as we share towards the end of today, we'll provide contact information for plans where, as you communicate and follow up with plans, you can ask questions, but also even get the plan-specific assessment forms beyond the HealthBegins designed CBO Readiness Assessment. So you'll hear more about that as next steps at the end of today. But as we think about the readiness assessment and what it represents, it's a multi-page assessment form. We wanted to highlight in particular some of the key domains that we've heard already in conversations with our plan partners and several of you, as well as other community-based organizations across the state. One thing I'll note is that this project that we're presenting today, this Medi-Cal CBO Partnership Development Network, started out with conversations as early as January of this year with many community-based organization leaders and plan representatives and other experts in the state to think about how to create an opportunity for CBOs to pursue contracting relationships with plans. And through those set of conversations from January to now, we actually have a sense of some of the most high priority or highly encouraged kind of domains to really focus in on. And so what we're going to present today is some of the domains that are in that readiness assessment, not all, but just to highlight. So for example, one of the things that's so important to understand is what the plans are doing in terms of vetting. Providers are in many cases required to be, or in all cases required to be Medicaid enrolled, where a state level enrollment pathway exists. But if there's no state level enrollment pathway for Medi-Cal, plans, the managed care plans, are required to vet the qualifications of providers or provider organizations to ensure they meet certain standards to become a community support provider. The plans that are participating in this network, in this cohort that we have today, are required to vet CBOs that are interested in becoming a community supports provider. And so again, that's why contact with the plans is so key here, to make sure they understand the specific vetting requirements that each have. But at a high level, some of the criteria that plans may consider as part of their vetting process, including the plans that we have as partners here today, can include, but not necessarily be limited to, some of those elements you see on the left, whether it's the ability for the CBO to receive referrals in the first place, the degree of experience that a CBO has to provide services related to the populations of focus. This is especially important on the CBO side, but also experience providing the community support of interest. The ability for the CBO to submit claims or invoices, other business licensing or business capabilities, including background and compliance components. There's a whole list of provider terms and conditions that will also, there's a link here at the bottom, and this will be part of the deck that you receive too. So we encourage, if you haven't already, a really specific, diligent review of the provider terms that DHCS has provided, and of course, with the plan specific requirements. But at a basic level, as you can see on the right, there's some core capabilities that community support providers we know need to be able to provide. As we've worked with the plan partners to prepare for both this regional session and future sessions over the next 2 months, regional sessions and also county-specific TA sessions that will be coming online. And you'll see those dates towards the end of this conversation. As we've been preparing these TA sessions, including this one today, we wanted to focus in on these areas that receive the highest interest when we had those conversations with plan partners as well as across the state. And data sharing, contracting, billing, claims, and compliance are key domains of readiness that have been identified by the plans. So let's go a little deeper into those just to especially for those who are at an earlier stage of foundational knowledge about community supports, let's really try to help provide a higher foundation of knowledge when it comes to the service requirements. We know that providers for community supports must deliver those services in accordance with service definitions. And that's why, as Sadhana mentioned, it's really key to understand the service definitions that DHCS has provided. If it's important to understand that if a community support is discontinued for any reason, providers must transition planning for those members into other, must support transition planning, I should say, for members into other programs and services. So that's a key requirement, of course, because that's a possibility. Community support providers will be reimbursed only for services that are authorized by the plan, as you can understand. And if a Medi-Cal member requests services that are not yet authorized, the community support provider should send those requests to the plan for authorization. These are some of the basic service requirements. There are particular ones related to outreach and engagement we wanted to highlight here. Community support providers should also accept member referrals from plans and must conduct initial outreach to the referred member within 24 hours of being assigned that member by the plan. They must be responsive to outreach from members, including by maintaining a phone line that's able to receive messages 24/7, at least to be able to receive those. And then community support providers must coordinate with other providers in the member's care team, and that includes potentially other ECM providers in the community, as well as with the plan itself. So these are some important service requirements to understand for community support providers. When it comes to staffing, clearly there's a expectation, understandably, that the community support provider will maintain a certain degree of staffing and then be able to use that staffing model to act upon member referrals as well. So basic staffing requirements. Let me pivot from, I'm sorry, I'll pause here, yeah.
Yeah, I'm wondering if we should just pause there for a second on the service requirements and see, you know, how folks are hearing it, if it sounds new to them, if there's any questions. So maybe we could just pause here and let folks, you know, input any questions you might have on these service requirements that Rishi just reviewed, either via chat or feel free to unmute.
All right, I think I'm going to take that as a cue to
keep
on going, Sadhana, and then let's go to the claims and invoicing information. And after we go through these sections, Sadhana, to your point as well, we'll pause at several points just to make sure people have a chance to weigh in. But again, the recording of this session will be available. So for some of you who want to review the recording as well as the PDF at a later point to be able to socialize with other colleagues or stakeholders, that's entirely understandable. We want to make sure this is information that you access in whatever way is convenient for you, including in real time right now. Let's talk about claims and invoicing information. Pamela, this may get a little bit to what you were asking about as well, and we'll invite comments from everybody about this if there are particular questions about claim submission and invoicing. One of the expectations is that community support providers have the technical capabilities to submit claims or 837 claims to plans. And if you have that capability, if not, then community support providers that are unable to submit those claims in that 837 compliant way must work with an invoicing template that the plans provide. And this is an important point to pause and say that, again, that will be very plan specific. And so again, if there are plan partners on the line here as well, we can pause after this section here so you can provide additional insights or details about the particular invoicing templates. We also will indicate that that's if you have a question about the invoicing templates, that's something that you can follow up. We'll provide the contact information for the plans, and we'll also be able to follow up in upcoming sessions if that's of interest to CBOs in this cohort to go deeper into invoicing templates. And that's true for all the sections here, but especially when it comes to invoicing or data or claims in particular, this may very well be part of an upcoming county-specific TA session where the plan's own TA experts can be available to help answer some questions. In addition to the submission of claims and invoices, we know that community support providers must respond to all plan requests for information and documentation to permit ongoing oversight which I think makes sense to many of you who've already done contracting with plans. There's a certain degree of responsiveness that's required, especially to support ongoing monitoring. When it comes to just kind of a deeper dive on two specific questions within the question, data, billing, claims, and account reporting requirements, I wanted to highlight two questions in particular. One thing we've heard from some CBOs is understanding the minimum data elements. What are the minimum data elements that community support providers need to share with plans? And so you see here a description of some of those, including member demographic and identified information like the plan member ID. There's the services provided with the appropriate coding system, using the appropriate codes, and we'll highlight that in a second. There's also appropriate information on the units or the number of services provided, right? Medically tailored meals or housing, respite services, et cetera. And of course, information about the date that the service is rendered and the end date, if applicable, for the type of service that you have. For those who are curious to learn a bit more about how to submit compliant 837 claims or invoices, in some cases, to plans, again, we note that this can and will vary by plan. But one of the things that you may find helpful for CBOs in general that are thinking about this is to review some coding guidance that's been available by DHCS to learn a bit more about the Healthcare Common Procedure Coding System, or the HCPCS, HCPCS. Codes and modifiers or specific information, again, in this link that we'll provide here, that gives some details about what types of codes can be used to submit along with these types of 837 claims. I'll pause here just to see if there are any questions here to review. So I see a couple, one from Dawn. Just curious as to the staffing requirements when many entities are having staffing shortages. Thanks, Don. You're saying Shasta County uses coordinated entry and HMIS for the referral and priority. Not sure the community support referral requirements will work in the CE process. And then Josette, is there any thought to mixed billing, an ECM provider providing community support services as well? Josette or Don, I don't know if you want to voice those over just to make sure that we get the questions out of the table correctly, and then to see if there's anybody from our implementation partners or plan partners who are on the line who may want to comment on your questions. But Josette or Don, do you guys want to unmute? Don, I'm not sure if you can hear me, but would you like to just give some more context to the Shasta County coordinated entry question?
This is Dawn Patori with Shasta County. I am new to my position and new to a lot of the programs, but I have attended a lot of the CalAIM meetings and information sessions. So in Shasta County, we use HMIS, Homeless Management Information System, and the coordinated entry process to determine the level of need via scoring and linking those homeless in need with programs. And in the meetings that I've attended for the CalAIM and the community supports, our concern is we are already short-staffed and our staff are completely busy doing what we do now. Mm-hmm. And to try to add the new program or community supports and meet your staffing requirements and take referrals that are outside of our accepted coordinated entry referral process. We're just not sure how that's going to work in our county.
Yeah. Don, I appreciate that. I'll mention two things just for clarification. One, these aren't HealthBegins staffing requirements. So we're presenting these. So
thank you.
Yeah, just to clarify that point. But I think that to the substance of your point, though, which we take quite seriously. One thing I'll just mention as a available opportunity that's coming up in the early part of next year. And we know there are organizations on the line here who also have CBOs in particular have, I think, perspectives and answers perhaps to mentioning. There's another opportunity coming up in the spring that will be hosted by the Corporation for Supportive Housing. And that's a Medicaid kind of learning academy that is designed specifically to help housing providers, in particular those who work in supportive housing, permanent supportive housing, to come together and learn about how to address some of the very information sharing kind of challenges that you're highlighting, Don, as well. So just know that there is another opportunity for technical assistance to emerge in this space, because it's clear that there's not going to be a one in some cases, not a quick answer or a simple fix to aligning the CE coordinated entry system and process to community supports. But I just want to flag that as an opportunity that's coming about, and we may have an opportunity through this cohort to bring in some of the information from our friends at Corporation for Supportive Housing to at least share more about what that opportunity looks like. So encourage you to stay involved in this cohort to be able to connect to that. I'll pause there to see if anybody has some comments or reflections or any answers on the county level to Don's great question.
Hi, Rishi. This is Nancy from HealthNet. You know, in terms of responding to the comment about staff capacity and so forth, there is an incentive program for CalAIM meant to do just that. You know, help organizations who are providing community supports and ECM to build infrastructure capacity. And so I know that HealthNet is launching, and it may have not already gone out, a survey to assess the current network of community supports and ECM providers, you know, to gauge what your current capacity and gaps, you know, the opportunity to expand capacity and infrastructure through the CalAIM incentive payment program. And so I know, you know, be on the lookout for that, because I know that's going out any day now, and I think the survey will close on November 12th.
Nancy, thank you for that. And I think that's just to follow up on, I think through this cohort, we want to be able to just support connections to surveys like that, whether it's from HealthNet or Health Plan of San Joaquin and or from partnership. This is exactly the kind of information sharing that we'd like to kind of facilitate. So Nancy, as soon as you have that resource, and we'll follow up with you and the HealthNet team, we'll be sure to kind of disseminate that through this cohort, the listserv. Thank you for that. Other comments from other plan partners or other CBOs, to Don's point? Or if not, just to build on Josette, if you would like to unmute to talk about the mixed billing comment.
Sure. This is, you can hear me?
Yep.
Okay, this is Josette McCrolla, also Shasta County. And one thing that's been kind of bouncing around in my head a little bit is this, we have enhanced care management services and we have community support services that are being treated as very different things. But there are services listed within the community support that are medical in nature. So our enhanced care management contractor at this point is our FQHCs for whole person care. They provide, say, medical respite services or durable equipment purchase or you know, medically oriented services that our housing folks don't necessarily provide. So being that these are treated as very different services, how are we handling billing in that scenario? I mean, do they have to be contractors for both?
Yeah, it's a great question. I think this will vary by plan, but I'll take a first pass and then ask you know, others from the plan side and also, you know, Lucy from Aurrera to chime in to correct what I'm going to say here, and Southern obviously as well. But I think if there are CBOs that have the capacity and interest in providing both ECM as well as ILOS services, that both should be indicated in your communication with the plans to be able to indicate that you want to contract as both, become a provider for both ECM and providers for community supports. And in that conversation, then I think with the TA from the plan specifically, and as you think about the rates and look at that together, the conversation with the plan specifically allows you to make sure that you're, as a CBO, able to speak to both sides of it. Rather than have an entirely separate process, I think, you know, where a team on the ECM side from the plan is not talking to the ILOS side. I think from my understanding, the plans are really motivated to try to help align those conversations for CBOs that are in the situation you're talking about. But from the plan side, I invite anybody to kind of weigh in on that and add or edit what I shared. Does that sound right? Nancy, I know you were on the line, so I don't want to.
Hi, Rishi. Sure, it's Nancy from HealthNet. That's absolutely right. And we are coordinating between the ECM and community supports providers, and where the provider is offering both. And absolutely, that's we're seeing much of that, right? Especially with the transition of whole person care and health homes providers. Many of our whole person care providers have been providing ECM-like services, but really also the housing, some of the housing navigation tenancy support, for example. So it's not uncommon to have an ECM provider doing housing navigation and housing tenancy. What DHCS, has provided guidelines around is that we are paying separately now, right? Instead of kind of bundling everything together, ECM is a separate payment, then housing navigation, then housing tenancy, for example. I hope that does that answer folks' question. And I know various plans may, be operationalizing it a little differently in terms of the coordination. And please reach out if anyone has any questions.
Mhm.
And I believe Nai Kasich is on as well. She's the regional Medi-Cal vice president for our San Joaquin and Stanislaus region.
Thanks, Nancy. Thank you.
All right.
And go ahead. Sorry.
So if I'm understanding correctly, though those are differently billed processes, it is possible to have bleed over in whoever's providing that, correct?
Right. I think one
Absolutely.
entity. Go ahead, Nancy. Sorry.
Yes, so bleed over meaning an ECM provider is also doing the housing navigation tenancy. It could be the same, care coordinator doing it. You just get to bill it different, separately.
Okay.
Yep. And I know, Josette, you're in Shasta in particular. So as Nancy mentioned, with NIA as well, there's support in Shasta. Partnership Health Plan obviously is another plan partner in that space as well. So if there's anybody from Partnership that's on the line today, feel free to weigh in. And also, again, at the end of this conversation, we'll be providing, the contact information for many of our plan partners here, and encourage our plan partners who are on the line today to also share their contact information in the chat now so that we can facilitate the kind of Q&A. That's the great Q&A that's happening here.
Well, I do want to mention something.
Please. Yeah.
On a side note, it's just personally, I've been involved with whole person care since the beginning, and I'm involved with the CalAIM transition. And a great deal of what went into whole person care was a team approach and kind of a blurring of the lines. I mean, if we had a better rapport with our medical case manager than the housing case manager, then perhaps the medical case manager would be providing some of the service, or vice versa. It's not that clearly defined necessarily. And now we're taking this process, we went out of our way to make a combination service and splitting it into pieces. And that's kind of painful for me. I don't know about anybody else, but it's kind of painful to be splitting it all apart after we've designed it to be cohesive.
I know you're not alone, Josette, based on the conversations we've had with many community-based organizations across the state, including those that have already been working, through the phase one counties through whole person care or health homes. But Naya, I saw your hand raised. Did you want to?
Yeah, I just want to respond to that comment because, I think it depends on each county health plan that you're working with. But I can share with you in San Joaquin County, as an example, whole person care county, we are working really closely with our whole person care and talking through what other agencies that particular agency did in the last several years, because we certainly do not want to cause any disruption. We want this transition to be smooth as possible. And so to that end, what we are doing is we are working with that lead to help identify other support service, community support service providers that that entity is recommending for us to add. And so for us, that's bare minimum, and we're trying to expand because again, CalAIM's effort is to reset or rethink what a delivery system might look like. So to that end, we're actually adding other providers that this particular whole person care entity may not work with, but is supplementing to the list of 14 or supplementing what this agency has worked with in the past, and to try to pull in as many of the providers that are on that list of 14, along with additional providers, because just having, let's say, one provider for asthma remediation may not be sufficient, as an example, because we're talking about at least in San Joaquin County, a county that's very diverse, and there's a huge Khmer population, as an example, along with Spanish speaking population. So we want to ensure that there's adequate services and providers available. So we're not trying to create a divide. I think what's causing maybe some angst is the terminology or definition. So we have ECM providers who are responsible for care management as a primary role. And as Nancy had said, had mentioned earlier, that there's some providers that provide navigation services as well. So we want to honor that, and we want to honor any other agencies that prospective ECM providers want to work with, want to maintain that relationship, and then add to that list so that, again, there's an adequate list of providers that are available. Because again, Whole Person Care was a pilot program. The number of folks who were participating is much smaller. Moving forward with CalAIM, we're looking at expanding the definition and expanding the number of eligible populations. So we need to ensure that we have an adequate social services network. And so that's really important to us.
No, thank you so much for that. And also, Josette, thank you for your comment. And I think on both sides, part of the value proposition that we see for not just today, hopefully that you're seeing in real time, but the purpose of the sessions that we're providing over the next couple of months is to create a space for the key stakeholders here, county, CBOs, and plans to navigate what is this, among many other important dynamics that need to be addressed only with the key stakeholders working together. And this is not meant to duplicate the important conversations that are already happening, we know, in each of the counties, but meant to kind of expedite, especially the ability of CBOs, and to your point, the expanded number of CBOs that we know can have high potential to provide services to engage to engage in these types of direct or indirect relationships to start to provide these services. So how do we create a seat at the table for more CBOs to engage in answering some of those questions that Josette, you rightly answered, and you kind of spoke to?
Yeah, and that's fine. I just wanted to mention that sometimes we get on these meetings, we get very focused on ECM versus ILOS.
Right.
It's not necessarily adversarial like that.
Yeah, I really appreciate that call out, and I think our objective is not to kind of further the impression, especially for CBOs that are listening in who are maybe newer in your journey and are thinking about whether this is the right kind of opportunity for you or how to pursue it. We want to communicate, I think, that as you're hearing already on the call today, with Josette's great comment and Nai's response there, that we're giving you information about what community support providers in general are required to look at from the plan's perspective at a high level. But should you feel like you have questions about what this means to realign or how to frame your work, that's exactly the purpose of these sessions. So today is just the first of what we hope to be several conversations to help you understand how to see this as part of a bridged or a graded type of approach rather than a set of silos. So just at your point is, I really appreciate that comment, because we don't want to further any sense that there are silos here, much as there are specific requirements, of course, from DHCS about how to manage these services.
Yeah, and I just wanted to add, Rishi, quickly that I appreciate just that you raising it, just to also extend my appreciation for it, and that we're taking notes on the questions that are coming up through the chat, and that folks are unmuting and asking, because it does seem that a lot of these are plan specific or county specific. So we'll be sharing it with our plan partners and including that. And to Rishi's point, it isn't meant to supplant the conversations that you're already having with your plans or with your counties. But we will also be, pulling these questions together to raise up for those TA sessions or for one-on-one conversations as appropriate, whether it's, the payment conversation that we had earlier or this one.
Yeah. Thanks, Ella. Again, just kind of pivoting to maybe some foundational kind of requirements that we know that some folks on the line today might benefit from hearing. Again, with apologies to those CBOs that are perhaps further along in understanding this. Let's kind of recap some of the basic credentialing and compliance information that is key for any would-be provider, community support provider, or ECM provider. One of the credentialing kind of requirements for those who want to do direct work is so I'm just going to admit somebody, is the need for a national provider identification, or NPI. That's a 10-digit number assigned by CMS that's used for electronic claims transactions to support healthcare billing and reimbursements. NPIs are required for all ECM as well as all community support providers, or to just at your point, a provider that might do both, including non-traditional providers to receive payments in many cases. Employees and subcontractors of those types of organizations are not required to have an NPI at this time if they're not billing directly to an MCP, to a plan. So that's an important distinction. And again, this is where if you have questions about this, and if our plan partners aligned today have specific guidance, we know that this is also something that requires specific follow-up with each plan, but we wanted to at least share the baseline information about what an NPI is and flag this as an important consideration as you're thinking about your readiness as a CBO. If an organization, some of you already have an NPI number, it can be used to bill for ECM as well as for community support services. And those that already have an NPI should ensure that the taxonomy codes that are listed in their own current NPI profile reflect the licenses and the services that are relevant to community supports. The HCS has provided a list of the taxonomy codes that map to various community supports, and I think I have it on the next screen here. Oh, wow, sorry, my mouse got a little crazy there. Let me go back. Here's an example of the taxonomy codes. Again, this will be on the part of the PDF that we'll share with you. There's also links to various resources from the state, from DHCS. We also want to call attention to what we know Partnership Health Plan has put together as a NPI application step-by-step guide. You'll see a link to that here as well. And so the point is, if you already are an NPI, if you already have an NPI as an organization, thinking about how to align your licenses and services in that NPI profile with the DHCS recommended taxonomy codes is a key step. And so that's an important element for the supporting the credentialing process. I'm going to skip ahead just in the interest of time so we can turn this over back to maybe to Sadhana to talk about the kind of next steps here, and then we can maybe open it up then for broader questions because I think we're doing okay on time. But as Sadhana, I'll turn it over to you, I think, in terms of some of the next steps for the CBO Readiness Assessment and how to stay involved in the process, and perhaps we can then use that as a chance to kind of step back and kind of take some time to answer questions, additional questions.
Yep, that sounds great. Thanks, Rishi. And so we will be sending out the CBO Readiness Assessment. It's going to include some of the domains we covered here today. We will also send out, if you go to the next screen, actually, we can talk about the next steps to become a provider. So we'll be sending out this CBO Readiness Assessment. As we mentioned earlier, it's not intended to supplant what plans might be sending out as well. We are working with our plans to understand what materials are being sent out. So hopefully it'll be in alignment and not duplicative of what's being sent out. But, as Nancy mentioned, there's an incentive payment program survey being sent out by HealthNet. Partnership has a survey that's also being sent out. So we're trying not to be duplicative with those surveys, but to better figure out what to provide TA on. And so as honest as you're able to be on that readiness assessment, it'll be helpful for us to be able to create TA products that meet you at your readiness level, and also for plans to understand your readiness level as well. If you could assess the services you offer and the individuals you serve, and go back to that list, that resource that we had shared on provider guidance and definitions to see how it aligns with community supports if you're not sure. And then next steps would be to determine what steps you may need to take to participate and meet managed care contracting requirements. And that's going to happen through this process where, we'll have a series of sessions to help you determine those steps based on the readiness assessment and conversations that we have together in regional sessions like this, as well as in TA sessions. It'll be important throughout this process to prepare questions that you have for county and plan representatives. That was really, demonstrated well here today. We're not closing out quite just yet, but, having those questions is helpful for the county and plan representatives, as well as your peers, whether they're CBOs in your county or in other counties, for folks to hear and to think about as everyone's kind of figuring out their role in becoming a community supports provider. And then to signal interest to the managed care plans in your county. And hopefully through this process, those conversations come more easily if you don't have existing relationships with your managed care plans. We're hoping that this TA provision will be one way to start and develop and further those relationships so that you can signal that interest. And we have some contact information in the appendix to that end. And so if you go to the next slide, these are the upcoming sessions. And so we have 3 types of sessions. I know a number of folks on this call joined our statewide information session. That was intended just to give an overview of this project and to let folks know what we have in store for the months ahead. Our next statewide session will be more TA based. And so we're planning for that to likely cover CBO costing and budgeting. For community supports, it would be open to all California CBOs. So it's not, just for this group here or for those 4 counties that we mentioned at the top of the call. It will be all California CBOs. So you should feel free to invite your networks when you get that invitation. And I did see, Pamela, you mentioned, wanting to include your agency in future conversations. If you're on this email list, you'll be included on the email list for all statewide sessions as well. The 23rd, we're planning a TA session for San Joaquin and Stanislaus CBOs, really aided by our plan partners at HealthNet and Health Plan of San Joaquin. So that will be kind of one of those more targeted TA sessions where we can get into a little bit more personalized conversations related to the plans for those counties. We'll have another similar session to this one on November 30th, where we'll bring all 4 counties, the CBOs from all counties, 4 counties together again. And that same day, we're going to have a TA session in the afternoon for Sonoma and Shasta CBOs with partnership, Health Plan of California, helping us with that one. December 10th, we'll have another one of those. And then in early December, we're still planning the dates on these. We're going to have another statewide session and then a TA specific session for the 2 counties, San Joaquin and Stanislaus. So tomorrow we will send you a post-event survey. It might come out later tonight so that you can complete it tomorrow. We really want to see if we're hitting the right kind of marks in terms of clarity, in terms of content, and to also gauge where you are in this process. If you're looking towards contracting now, if you're not, things like that, the survey should take 1 to 2 minutes. So please complete that if possible by November 4th. So those are our next steps. I'm wondering if we want to go to questions now. And kind of open it up for folks if there's things that, as Rishi mentioned, this is kind of a evolving process where we want it to be engagement between the CBOs as well as with us. Are there questions that maybe we could answer today or that you're hoping we'll answer over the course of all of those sessions that we outlined that are important to you? And kind of allow folks to unmute or chat in as you prefer.
One thing I might do is just to build on your point there. At the beginning of the conversation today, we had that 1 to 5 scale, in terms of how knowledgeable do you feel about the basic requirements to become a community support provider. At this point, if people, especially the CBOs on the line and our partners in the counties, could take another pass at that on a scale of 1 to 5. Do you feel how knowledgeable do you feel now about some of the core requirements to become a community support provider? Has it changed the needle at all, or is it pretty much the same? So just give us on a scale of 1 to 5, 5 being very knowledgeable now about what it means to become a community support provider, 1 being not knowledgeable. Thanks, Corinne and Des. 2 to 5. Thanks, Pamela. We'll count that as we'll compare that to your answer, Pamela, and see if there's an incremental change.
Yeah,
but...
it's just a bit better. Really helpful, though. Thank you.
Good. Thank you. Corinne, I wanted to ask if you don't mind, and thank you again for being so candid. What's most of interest and important for you to help? And if you could just speak a little bit more about the work you're doing. Corinne, you're with the committee on the shelter list.
Yeah.
What's of interest to you right now?
Yeah, I guess it's just about moving into the space of Medi-Cal and billing and reimbursement rates, kind of understanding the the compliance requirements and how really to stage your organization to get up to that speed. If you don't have familiarity with Medi-Cal and how to move into this space.
Yeah. Does it feel, so you mentioned 1 out of 5 there in terms of knowledge about it. Do you feel like, is that a reflection of the kind of confidence to move forward in a contracting relationship, or is that a reflection of just the knowledge of like what's required?
A bit of both. Whether we have the capacity, especially, looking at staffing shortages and referrals and, whether, we have the capacity in our organization to take this on, but it's so important that really wanting to stage our organization so that we can, and how to really navigate moving into these complex spaces in terms of understanding and making sure our organization is truly prepared for it.
Absolutely. I want to come back to that point in a second, but I also saw that Des has hand raised as well. Des?
I just want to say that I agree with what Corinne was saying around, to me, it feels like there's too many unknown variables. And so I'm having a really hard time wrapping my head around what this is actually going to look like. I mean, I basically have the requirements down, like that part is like, okay, I can read that. That's what, the basics. But moving forward, what it's going to look like, it's so vague. Well, billing, invoicing, it's like, it would be easier if there was a template or something that then you could adapt from. It's just, it's too vague. So I can't wrap my brain around it. And I'm not familiar, with Medi-Cal stuff. So I'm at a disadvantage there already. So, a lot of times when I sit in these meetings, I don't understand some of the other information. And then it goes so fast and everyone talks so fast that, I don't even know where to start with asking questions. So I just, it just feels like it's so vague that it's hard to know how to navigate.
Des, let me follow up on that, and I appreciate that feedback, especially for this, first regional session, which is in some ways about breadth and not about depth, right? Because we have CBOs and stakeholders from 4 different counties represented here. But your feedback is spot on. In our to balance that out, as we were thinking, as we got feedback from many community-based organizations and lead up to this, we knew that there was a need for kind of foundational information as well as for a deeper dive, plan-specific kind of conversations to really get concrete about, all right, what does this look like? The use of templates, to your point, was one of those. And that's where the thought was to start with regional sessions, today being the first of that, that brings organizations across counties together, and then follow up, as Salvin mentioned on one of those slides, with county-specific conversations that allow for more specificity of information from the plans to say, here's exactly what we mean, and here's exactly what we need, here's exactly where to start, here's the template, in that way. So the county-specific sessions that are coming up, we had assumed would be the best way to try to get that depth and that specificity. But again, I appreciate I'm not sure if it doesn't answer your question, but it's an insight into how we were thinking about providing a scheduled set of conversations over the next couple of months to try to help support foundational breadth, right, of knowledge, and then deeper dive conversations in the county. And it sounds like the latter is more of interest to you. Getting concrete stuff in Sonoma to talk through with the plans. Is that right, Des? Your preference is
Yes.
specific templates.
Yeah. I mean, I'm a little concerned about the timing because here we are in November and all of this is happening, supposedly January 1st. So I feel like in the next couple of months to get that stuff doesn't ease my anxiety about it, because we're supposed to be planning things over the next couple of months. But I appreciate that you guys are at least thinking about it and going to try to get a little bit more concrete. So some of us who don't have as much experience, can have a little bit more guidance.
I'll make one quick comment and then I turn it over to you and to Savana as well. What was so helpful about this is the timing. When we met earlier in this year, just to flag that there was a need for kind of space for these conversations to happen, and the feedback we got earlier in the year was we need to structure some sort of opportunity for CBOs and plans to support some of the conversations that plans are already having with multiple CBOs already. To Nai's point earlier, we wanted to think about how to provide more space for more CBOs, especially those who are not already engaged in relationships with plans to kind of come to the table. So there was an urgency we heard even earlier this year about creating that space. At the same time, there's a lot of, and still is, it's a little less now compared to 6 months ago, certainly, but there's still uncertainty in terms of what this actually looks like, because we're planning for something that's going to launch on Jan 1, and there's a recognition that there's going to be a lot of calibrating that's going to keep on going, probably in 6-month cycles, right, for the next couple of years of learning what it's like and then squaring away. And so the value proposition of this particular cohort is to try to create the space initially, knowing that we're not going to solve all TA needs in 2 months. It's impossible. It's not what we're communicating as the value proposition for this. The hope is that it's at the very least a way to start to identify what TA needs are most important and help the plans start to hear, okay, where the needs are, and also help the CBOs hear where the opportunities are, so we can facilitate, faster information sharing. But long way of saying amen to your point, and I really appreciate it, and particularly the candor from you and from Corinne on what you're feeling in this process. Naya, I know you had your hand raised earlier, and Sadhana, I want to turn to you as well. But
yeah, really quick. I just want to respond to Des's comment around the level of anxiety. I think whenever we see anything new coming down the pipeline, we're all very concerned and anxious. To that end, I'm just kind of curious whether we can get some ideas or suggestions that may help reduce that anxiety. So what kind of guidance, what does proper or appropriate guidance look like to you all? I know we don't have time here because we're just really at the half hour, hour and a half. Maybe at another forum, or if folks can email us some of your suggestions that may help bridge that gap and reduce your anxiety. I would love to hear suggestions from this audience.
Yeah, I think that's great, Naya, and definitely welcome that as folks are kind of reflecting on today's session and the kind of the materials that exist out there. If there are specific things that are coming up for you, or we'd love to hear about that. And I think the only thing I wanted to add, Rishi, to what you had said about our thought process going into this was, to be able to have these broader conversations as well as targeted conversations that included the counties, and also to try to not be duplicative of the materials that are existing out there. So the 101 content or the 102 content. And yet I think hearing Des, your comments, it sounds like there's more that we could do in terms of like bridging that 101 and where we are in our conversations. So we'll give some thought to that. Hearing both, I think Des and Corinne talk about, trying to figure out where to start and where to stage the organization with all of the information that is kind of spinning around them. I don't know, Nancy, if you want to give voice to what you just mentioned.
Sure. I know, there's lots of questions and confusion with CalAIM. The health plans are also in that situation, right? We're trying to interpret all the DHCS guidance, and, at times, many times working with our plan partners within each county and DHCS to pivot, where maybe there are areas that that are not in the best interest of our providers and members, for example. And so we are, in terms of training, because I think the more information would be helpful, for everyone to sort of be on the same page. We are recording live webinars. The webinars are meant for those we are planning to contract with. And so those will be attended by those providers, but they will be recorded, and the recordings will be posted on our provider portal on the pre-log on section, which means that anybody can access it. So I'm trying to find out now when that will happen, because some of the live webinars are still happening. They're getting launched, just right now. But they will be posted on our website. And it will have, managed care 101, sort of basics of billing, and, our kind of health plan operational structure. There would probably be the NPI information there, more of the operational details for onboarding content.
That's great. Thank you for sharing that, Nancy. And I see, Rishi, you have on screen the MCP contacts by county. These are the generalizable kind of general email addresses for the counties. We'll work with our plan partners to see if there are additional kind of emails that they'd want to provide to this cohort. But at the very least, these are good emails for folks to have as we move forward in this process. And it's part of the appendix in the deck as well. So you'll receive these. So I mean, we can close out here. I don't want to cut folks off if there's anyone else that has any questions that we could address at this point. But if not, we thank
Sadhana?
Yeah.
I'm sorry, it's Nancy from Health. That one thing, if I may, if I wanted to share is, although health plans had to provide, who they plan to contract with, kind of the first round of contracting, since that was due to DHCS in the model care submission on October 1st. It doesn't mean that, there are additional opportunities for providers, particularly local community supports and ECM providers. Right now, I think what, we're seeing and what we're doing as a sort of health plan is trying to make sure that there's access to the services statewide in all 31 of our counties. If we recognize that it is important to contract locally. And so that's really the next iteration where if we're not contracting for specific community supports in a specific county locally, or there are additional providers that should be in our network, right? Because you're doing this work in the community and we want to know about that. And that's really this partnership with HealthBegins in trying to bridge where we can eventually contract with you, help increase capacity and so forth, and contract in the next iteration, because we are contracting continuously. The next round will probably in a few months. And as you know, populations of focus will also be expanded for ECM, right? And so health plans will also be doing sort of another round of contracting outreach to community providers, for those contracts as well.
Nancy, I really
go ahead, Rishi.
Sorry, Zan, just a quick reflection, just to build on Nancy's point, and really appreciate that point. If I was to summarize like kind of the intended value proposition for this work, why HealthBegins is interested in hosting sessions like this, it's really to help improve the knowledge and the readiness of CBOs at different stages to be able to move further along in understanding whether and how best to contract. Right, to become a community support provider or ECM provider. We recognize that means that the hope here is that through this, as well as through activities that we hope to continue in January and beyond, to match, Nancy, your point, which is that there's a continuous process of contracting that we know the plans, including what you just mentioned for HealthNet, will take part in. It's a continuous process, and our intent is to make sure that as many CBOs, especially CBOs that have historically not been able to take their high value services and engage in this very complex space that, Corinne, that you rightly pointed out. This is incredibly complex in Medi-Cal, and we also know it can be very daunting, and for some CBOs can be prohibitive, right, to even engage in this space. Our hope is to be able to help lower the barriers to entry for CBOs that have such high potential for Medi-Cal members across the state in moving further along that spectrum. It may not mean that by the end of December, one CBO that's early in their process will land a contract or be able to feel that's confident. That's not our goal. It's to move everybody further along in that continuum of increased knowledge, increased readiness, and to have this map out for the foreseeable future to be able to acknowledge that this is a continuous process, and we want more and more CBOs to feel more and more engaged and equitable in their standing as this process continues to evolve over the next 2 months, 3 months, 2 years, et cetera. So that's HealthBegins' position in this, and I want to make sure that everybody is clear about why we're motivated to support this cohort and cohorts to come. So I'll turn it back to you.
Yeah, thank you for that, Rishi. And also Nancy for your comments about, expanding the pool, not just because of what, Rishi was indicating in terms of, I think, our shared interest in expanding the, number and types of CBOs that have access to this information, but also that, everything is still evolving and will continue to evolve over the next year or so. And so we mentioned this at the top, just if you have organizations that are peer organizations in your communities that you think should be included in this, please bring them along and nominate them for this TA provision. I think it's going to take early, like folks that are early in the continuum of learning, a few extra touches. I think folks that were at like a 4 coming into this may be able to contract earlier than maybe folks at a 1, but to Rishi's point, we're trying to broaden the ecosystem, make it more equitable, and bring as CBOs, especially in these 4 counties, further along in their process. And so however you, see a role for your own organizations or peer organizations in that, it would be helpful for us. So thank you all for your engagement today. This was great, for your candor, for the suggestions, for the questions. We will be following up. I know we're ending a little early here, but I don't want us to draw it out if there are no additional questions. Feel free to send questions to me, Sadhana at HealthBegins.org. I think all of you should have an email from me through this process, and we'll be able to include it in our conversations with plan partners and in consideration for future sessions. And we will send out that survey by tomorrow so that you all can give more feedback on what you're looking for, and we'll send out that readiness assessment as well. So look out for those 2 things from us in terms of what we would like you all to complete. And then we'll be sending out the recording and a PDF of the slides when that all gets rendered. So thank you so much for your engagement and for all of your time and energy. And thanks, Rishi, for including this in the chat. Just special thanks to our implementation partners. Again, Aurrera Health, Transform Health, also Neighborhood Educational Center, Mount Auburn Associates, for helping us together. Thanks all.